Hi, everyone. Welcome back to House Healthcare. It's 1:20 on the 14th, and we're switching our attention to H233, inoculating the pharmacy benefit management and Medicaid wholesale drug distribution, although that last section is going to change. So we have several people with us today. I've asked DFR to go first because they have a time commitment. So welcome back.
Thank you. So for the record, Emily Brown, Deputy Commissioner of Insurance at DFR. So again, I'm just going to be kind of referring to different sections of the bill. And Sebastian and I during our testimony. Do you want to introduce yourself?
Yeah, for the record, Sebastian Arguendo for the Department of Financial Regulation.
So the first comment I had, and I'm just kind of going in order. This is on page 7. And it's the section 3604, which has to do with reporting.
Yep.
So my question was more of a clarification. Is this this is an annual reporting requirement, so it'd be annually, or is it just for next? Because it was just the January 15th. So is the expectation that every year the department would come and kind of write a report to the committee about the enforcement actions or how the market's functioning? Okay, all right. In the next section, we wanted.
Sorry, should we clarify that?
Now that I'm reading it, I think it is clear. It's just, I think when I first read it, I was unclear because there wasn't a date. So that was more just probably for my own personal clarification.
You're okay with that?
Yes, that's totally fine. The second section we wanted to talk about was licensure. And for a lot of our testimony, we're just going to be referring back to our report that we submitted last year, the Act 131 report. And the department does support licensure. Right now, PBMs are not required to be licensed. So even though we have a lot of statutes on the books, there's no requirement right now that a PBM has to be licensed to operate. So we feel licensure will add a little bit of teeth to our regulation and give us a little bit more power to regulate the PBMs that are existing in our market today. So we support generally the licensure provision.
Art?
Is the licensure in other states around us, do you know?
Yes.
Yeah.
So we, again, in Appendix A of the report, we've made a table of all of the states in the country that have either licensure or registration laws and noted which kind they have. Most of the states in the Northeast require licensure.
Yeah.
Thank you.
Alan?
Is that $500 a one-time fee
No, I think that's annually.
annual?
Yeah.
We may be talking about, we will talk about those numbers.
Okay.
Yes. Okay, so DFR supports that section.
Correct. The rest of the sections, I think, going back to our report, we're neutral on. We tried to outline the pros and cons. I know there's a section on rebating and then the spread pricing. So the department's neutral on those, but we, encourage the committee to refer back to our report. And if there's any questions, about spread pricing or rebates, I will defer to my colleague, Sebastian. So I think that kind of concludes our direct testimony on the bill, but we're happy to answer any questions the committee might have.
Okay. So I have a question. When we got it, we had a list because PBMs are required to register now, not be licensed. So we received a list from the Game Ag Care Board. And there's a lot on there. I was really surprised, actually.
Yeah.
So it seems like there's different types of entities. Can you explain the difference between them?
Yeah. So there are pharmacy benefit managers that you can think of in broad terms as providing full service pharmacy benefit management in terms of managing the formulary and processing claims. Then there are pharmacy benefit administrators that only do some of these services. usually limited to processing claims where they let the plan manage its own formulary and negotiate rebates and all of that stuff. So those are the two broad types of entities that provide pharmacy benefit management services. Depending on how broadly you'd like to define pharmacy benefit management for the purposes of this legislation, you could capture both kinds of entities.
Okay.
Where are you seeing that list, Lori?
It isn't, may not have been shared with you.
I don't think so.
I apologize.
I think Claire has it, then can be
Yes.
put on our
Yes.
website.
Yeah, I'd like to see it.
The yeah, this
Public data.
this is available on the Green Mountain Care Board
Sorry about
website.
that.
Okay,
So if you
It's just a list of companies.
Right.
It's
Yes.
pretty much what it
right,
is.
yeah, I mean, it'd just be, you wouldn't think there'd be many, but
I know, I was shocked.
There's
how many are
There's
there?
like 300, right?
more than 300.
300?
We want to be shocked like.
Yeah. Yeah, so I apologize. I should, you should have put that out there.
the PBM market in general is a sea with 3 whales and many minnows.
It is a lovely.
Metaphor.
Go ahead, Ari.
In regard to that, then, okay, I mean, who would we license? Anybody that does anything in the state, I assume they're not located here.
Yeah,
I mean, who do we, if you do one thing here, does that mean, I wonder how you,
yeah. So
something that's
In-
kind of like,
in other lines of insurance, questions like that are addressed in what we call the de minimis statute, which is 8 VSA 3368. And in that statute, which I think we've talked about here before, the department's jurisdiction over out-of-state insurers is limited to insurers that have more than 25 certificate holders in the state or are actively marketing plans in the state. So for instance, especially in southern Vermont, there are many people who work in Massachusetts and are insured by Harvard Pilgrim, but because those plans are tied to employers outside of Vermont, the department doesn't have jurisdiction over Harvard Pilgrim.
Art,
kind of, yeah.
Mari?
A comment and then a question. In addition to the PBMs and PBAs, we've talked about on that list of 300, there are also insurance companies listed that have a part of their structure PBM functions. So that's why they're pulled into that list as well, correct?
Yes, so if you'll recall my earlier testimony, there's a lot of vertical integration happening, usually with PBMs and pharmacies, but now more with PBMs and insurers. So to the extent that an entity has a PBM that's affiliated with it or part of the same corporate structure, that entity might be registered for VCures as that entity, for instance, an insurer. I take your point, Representative Cordes, that the entities that have reported themselves as PBMs do not capture the entire universe of entities that perform PBM services.
And then my question is, as we think about where we want to set licensing fees. For all the little fish, I think in the Act 131 report, and maybe what you were just referencing, you mentioned there are under current statute protections possibly. And I want to get clear about this for, the little fish.
Yeah, so if we were to apply let's say that PBMs were required to be licensed in Vermont and we were to apply the de minimis statute, a PBM with only a handful of Vermont covered lives would not have to seek licensure to operate within the state.
So is there a minimum? Am I missing
Well, so
something there?
that could be an added clarification. So the statute that Sebastian mentioned is a general insurance statute, and it's in Title 8. This is Title 18, right? Correct? All right. So it might make sense to clarify, like if you wanted de minimis standard, right? If it's 25 lives, if it matches the current statutes in Title 8, you could do that. And it might be helpful, or we could also do it in rulemaking post statute if we get to that point and then decide that we need a rule to lay out which PBMs, if it's 25 lives, 50 lives, whatever makes sense for the market.
Seems like the latter option might make more sense so that we can customize.
Yep.
Yeah,
Instead of trying to figure out what that is and put it in statute and then things are changing.
Yeah, and I believe there's rulemaking authority in here, right? So we can do that. And you could include, I've seen sometimes, it might say rulemaking, including de minimis, licensing requirements or something like that.
Because it's been hard in establishing the licensing fees, looking at New York charges $24,000 every 3 years, $8,000 a year, Minnesota, $8,500, other states just register and it's $0. Ohio, I think is $4,000. I think the states that have done the most recent and broader, deeper work on PBMs are charging. And in looking at their rationale for the licensing fees, it was all to say we need to be able to support the work of the agencies that are going to be doing the licensing, enforcing, oversight, regulation.
Yep.
So it was all for the same reason.
Do you need resources to do the licensing?
Under our current structure, we would not be able to perform the licensing function without staff.
Okay, so can you provide us a number proposal?
I think I thought we communicated with JFO on it, Nolan.
So we're working on that fiscal note.
So we do have a fiscal note already that we could, I think, Nolan
I
already.
don't think it's done yet. We'll figure that out.
Okay,
Yeah.
but yeah,
We have something I can,
we have communicated, and that, again, it was in our report kind of outlined what other states of, I think, similar size have done or structure, so.
it was about $400,000.
So in the rulemaking language, it does not, I guess, help me understand. So I'm on page 6, 3603 rulemaking. Does not talk about rulemaking on the licensing. Based on that last conversation, would we need to change the language?
Yeah, you could include, and I defer to legislative counsel, but I think you could put it in that as, under that second sentence about the rules shall include as appropriate, you could add licensing in there. Or you could also put it as the rules shall include. Because right now it's, it's shall. Okay, yeah, it is shall. Okay, so yeah, you could put it in that list.
The rulemaking.
Yeah, it starts on line 17.
Jennifer Kirby, legislative counsel. I think all of what everyone's saying makes sense. There's also a specific rulemaking piece in the licensing section.
Oh, okay.
On page 8, the last, if I remember the one. It allows the commission to documents to establish the licensing application, financial and reporting requirements. And so maybe that would be a place that specifically call out to this.
Yeah.
But I think either.
Either one.
Okay.
Yep.
Great, thank you. As long as you have that note, Jen. Any other questions for DFO? Great, thank you.
Thank you. Appreciate it. Yeah.
All right, I think we have Sam. Hi, Sam.
Yes, good afternoon.
Welcome. If you can introduce yourself for the record and then go ahead with your testimony, that'd be great.
Yeah, absolutely. Thank you, Madam Chair. So thanks, Madam Chair, and members of the House Health Committee. My name is Sam Hollmeyer, and I'm here with Pharmaceutical Care Management Association, otherwise known as PCMA, which is the National Trade Association for America's Pharmacy Benefit Managers. Madam Chair, I did have a presentation, if it's okay to share with the group.
Yep,
Go ahead and do
Claire
that.
will give you access.
Okay.
Should be good to go.
All right. Can you all see a
Yes.
title slide? Excellent. Okay, great. So I'm here today to testify on House Bill 233 as opposed, but before I dive into the specifics of the bill, I am going to start out with a quick primer again of what PBMs are. But as I go through this testimony, I do encourage you all to interrupt me with any questions that you might have. I certainly welcome them. So let's go ahead and dive in. So what is PCMA, or who is PCMA? Sorry. So PCMA is the National Trade Association for America's Pharmacy Benefit Managers. And I heard a claim earlier that, there are only 3 PBMs that dominate the market. But as you can see, PCMA has over or close to 20 members who serve a variety of payer populations, also in particular and by region as well. We feel that there's a lot of competition in the market, and the bidding process is very competitive among PCMA members. So what exactly is a PBM? So a PBM is a healthcare company hired by insurers, employers, and government programs to administer their prescription drug benefits. So when you go to the pharmacy and you pick up your prescription, and the pharmacist is looking at their computer and typing in information, they're usually talking to your PBM. And I'm going to go into a little bit of detail exactly what they're talking to when it comes to your PBM, but I wanted to give you a quick overview of what exactly is a PBM. And then who exactly hires a PBM? So the PBM client can be many different things. It can be from the private sector to the public sector. Also, there's commercial health carriers and then government programs, just like the state employee plan in Vermont. And then also labor unions utilize the services of a PBM, excuse me. So there's a lot of various clients. So then why do they even use a PBM? So PBMs exist to do one thing, which is drive down the cost of prescription drugs. And they do that by using a variety of PBM tools, which I will get into a later slide. But one thing I want to start off with is that prices of drugs are not set by PBMs. In fact, PBMs have no say in the price of a drug. But what PBMs can do is they have tools to create competition among drug manufacturers to drive those costs down and making them more affordable for plans and patients. PBMs also do have insight to medications patients are taking to avoid things such as drug-to-drug interactions, and improving adherence, which is making sure that patients take their medications, and then just holding down rising costs of prescription drugs. Again, PBMs exist to deliver savings. So here is the variety of tools that PBMs use to save on prescription drug costs. PBMs are responsible for creating the system we use today of the real-time pharmacy claims processing. So unlike your medical portion of the benefit, when you arrive at the pharmacy, your drug claim is processed right there instantaneously using a paperless system. It's all electronic, so the patients know exactly what their costs are at the time of purchase. Typically in the medical benefit, a patient doesn't know what their costs will be until after that medical procedure or code is administered. In the same way, health benefit carriers negotiate to create a network of doctors and hospitals, but PBMs negotiate with pharmacies to create pharmacy networks. And in these pharmacy networks, we push for high quality performance as well as discounts to save for plans and patients. And then we also conduct audits to minimize fraud, waste, and abuse. PBMs also negotiate with brand drug companies for rebates. So I mentioned previously that PBMs have no say in the list price of a drug, but what PBMs can do is negotiate rebates to drive down the net cost of those drugs. So PBMs also encourage the use of cost-saving measures such as generic drugs, the utilization of home delivery, mail service pharmacies, and specialty pharmacies for drugs that treat complex conditions. We also provide coverage recommendations as well. Basically, we can help plan sponsors navigate their coverage options and identify a plan and benefit design that best serves the needs of their plans and patients. PBMs use independent clinical committees made up of medical and pharmacy experts to evaluate clinical evidence to help with the formulary recommendations. And these PBMs share with the plan sponsors these savings that these P&T committees can make. So then PBMs will work with plan sponsors to evaluate whether modification or add-ons to a formulary, which can alter or enhance the plan offerings as appropriate. And finally, there's something called drug utilization review, and it's something similar you might be heard. It's called prior authorizations or step therapy. And this is another way that PBMs are improving patient care. So when you arrive at the pharmacy to pick up your prescription, and this I'm going to get to my example where you see the pharmacist typing into the computer, they're talking to your PBM. And instantaneously, the pharmacist can tell you what other drugs you might be taking and any sort of interactions that there might be. Whether the prescription you're taking is negatively going to impact you or anything else you're already taking, like I just shared, and then whether it's the appropriate dose based on your age, weight, and diagnosis from the doctor that gave you. So basically ensuring that patients are taking their medication consistently ensures that people are healthy and you're not having complications that lead to doctor visits or hospital stays, which would increase costs. I'm going to take a quick pause. Any questions so far, or do you want me to keep going?
Any questions? Leslie?
Thank you, Sam. I saw that big number of PBMs in that earlier slide, and I'm wondering who they are responsible to. Are they shareholders? Who drives the business?
I believe most of the PBMs within PCMA's portfolio are publicly traded companies. So I think to answer your question there, they are publicly traded companies. But at the end of the day, the PBMs, they are the clients are their payers and the people that are offering those benefits.
Right, but it's different than being a nonprofit, I suppose, or being motivated by the shareholders' desires as opposed to another entity. I'm just trying to understand the system.
Yeah, again, they all, from my knowledge, most PCMA members are publicly traded companies. I will go back and look and see if we do have any nonprofit PBMs, but from my knowledge, we do not.
Thank you.
Mm-hmm.
Sam, this might be something you'll cover later, potentially, but you mentioned it, so I want to bring it up. I don't know if you had an opportunity to read the Act 131 of 2022 report that Department of Financial Regulation put out on January 5th, 2023. But in that report, the very last page, 58 of 58, it shows two scenarios. One, where a manufacturer had a list price with a rebate from a PBM, and one where it did not. And it showed, this example showed that the total expenditure of the drug ended up being cheaper without the rebate. And you had mentioned that rebates help to bring the cost down. So if you haven't seen this page, then I'm going to ask that you look at it and then come back to us. But it would be helpful to understand where that discrepancy might lie.
Sure. I believe that was the Madam Chair that asked the question. I'm sorry. It's hard for me.
Yes, it was.
Yes.
Sorry. Yes.
Yeah, you're fine. So I don't know that specific page or example off the top of my head, but I would be happy to go take a look at it and come back with a response for you. Just to repeat back, it was on the last page, which is 58. And then again, it was like two scenarios where there's a list price with a rebate and then another one without a rebate, correct?
Correct. Yes.
Okay. Yeah, I'd be happy to look at that, Madam Chair.
And if you don't have the report, our committee assistant can send it to you.
Great. Thank you. Okay. Any other questions before I move on? Excellent. So how do PBMs enable patient access? So when drug prices are skyrocketing, And PBMs use the tools that I just mentioned previously to keep costs manageable for plans and patients. We do reduce waste and increase adherence to avoid unnecessary hospital visits. And then home delivery is when a PBM will ship a medication to a patient's home, usually with a discounted copay. And then again, negotiating rebates on high-priced brand name drugs, as well as specialty medications. And then on the side there, you see a box that PBMs can help save patients and payers up to 40 and 50% on their annual drug-related medical costs compared to what they have spent without a PBM. So say a plan wanted to negotiate directly with drug manufacturers and not use a PBM, our data shows that it would be up to 40 to 50% more expensive for them to do that. So what tools do PBMs use to keep down costs? So I did mention previously, there was a bunch of little icons, but I want to focus on three things here. And these are formularies, rebates, and then utilization managements. So as pharma continues to raise their prices, PBMs will utilize the following, and I'll start with a formulary. So a formulary is a list of drugs, which is approved by a PBM and a plan sponsor. But I want to note that there are always exceptions process that a patient can go through to get access to a non-formulary drug. It just comes at a higher cost. So what these formularies are is basically a list of drugs that the plan sponsor agrees to. And drug manufacturers will offer rebates to get more market share to be on that formulary. So we find that negotiating rebates to get on these formularies drives down the cost of drugs, and drug manufacturers will offer those rebates, again, to gain market share on those formularies. And then rebates, I have touched on a lot. Rebates are discounts on drugs when there's a competitor available. So if there's a drug manufacturer that has no competitor or no other drug that will compete with it, there's no reason for a drug manufacturer to offer a rebate. And then finally, utilization management is things such as prior authorization and step therapy to ensure that patients are on the right drug with the right dose to reduce medication errors and waste. But also prior authorization makes sure that patients are using the lowest cost, equally effective drugs as well. So now this next slide I'm going to get into is a little complicated, but it's somewhat on purpose, just because of
So you know what, Sam, hold on. We have a
Sure.
question.
Sure.
Go ahead, Art.
Yeah, could you go back a slide to the pre-situations? There we go. The rebates. Rebates get passed through to health plans who can use savings to lower premium and other patient costs.
Correct.
That suggests to me that the PBM doesn't keep the rebate.
It depends on the contract. So a plan sponsor can request that 100% of rebates be passed through, or they can request that the PBM retains some of it in order to pay for PBM services. The statistics that we have found amongst our members is that PBMs pass back up to 90% of rebates back to the plan. Now, I'm sorry, I don't know off the top of my head if Vermont has a statute, if those rebates are used to keep premiums low, but typically that's what we find plans do, is to keep premiums down with those rebate dollars that PBMs negotiate.
Okay, so we've had lots of testimony about PBMs in here.
Sure.
For the last 2 or 3 years. And the rebates sound to me like a drug company buying space on your formulary. That's what it seems like. And I don't know if that is what it is. I don't know if the competition between drugs, the highest rebate wins in terms of being on the formulary. I would love to know from an expert what how a rebate really works. First of all, a rebate doesn't make sense to me in terms of a name. When I think of rebate, I think of something very different than this. But could you go over how a rebate works?
Sure. So
when we have time
Yeah.
for this.
I can do it now. Yeah, is now okay to go?
Yes, yes, please.
Yes. Thank you for the question, Representative. So rebates started for drug manufacturers to gain market access to get on a PBM's formulary. So think of a rebate as a discount. So say there's drug A and then there's drug B, and they both do the exact same things, but they're made by different manufacturers. What happens is PBMs will go to these separate manufacturers and pit them against each other to get to the lowest or to get the highest rebate, which results in the lowest net cost. So they might have different list prices, but what happens is they're going to negotiate on rebates, and whoever gets to the lowest net cost is typically going to get formulary access and more market share.
Okay,
Does that help answer?
yes, that makes sense to me. And then you're saying okay, so you get a lower price. So is it paid back or is the price just lowered? In other words, say a drug costs $100 and the other one costs 120. You get $20 off the 100 one and 20 off the other. So the $100 one wins. Now it's at 80. So do you pay 80 for it to put it on the formulary? Is that how it works, or is that 20 now passed through so that the farmers can get it for 80?
Sure.
I'm just trying to understand the system here.
Absolutely. And I'd be happy to follow up with more materials on this. But for the instance that you just gave, and the PBM went with the drug that had the $100 list price, but then the $20 rebate, which net makes it $80. What happens is over time, PBMs will process claims for, let's use the state employee plan in Vermont. So over time, the PBM will process claims for the state employee plan in Vermont. And at the end of, say, a quarter or 6 months, what happens is the PBM is going to say, okay, there were 100 claims on this drug. We go back to the manufacturer and say, hey, we got 100 claims on this. You owe us 20 times 100. And that check is cut to the PBM, which then is passed back to the plan. So to answer your question, we pay the list price, but then we get the rebate.
It's a true rebate. Okay,
Yeah, it's a true
see.
rebate, correct.
I see. Okay, thank you.
Melanie?
I'm just trying to understand, you're saying that the PBMs are here to deliver savings, and these are tools that you're using to do that. How long have PBMs been doing this type of work in the US?
Yeah, so PBM, oh, I'm sorry, go ahead.
No, that was, go ahead. Yeah.
Yeah, so PBMs did start as a administrator, just adjudicating claims, but as drug prices bubbled up and began a lot more expensive, PBMs found an opportunity to pit these drug manufacturers against each other to generate savings for plans. I don't know off the top of my head. I think PBM started in like the 1970s, but obviously the healthcare marketplace has evolved over time, and so has the PBM, along with others in the healthcare supply chain as well. So where we are at today obviously looks a lot different than where PBM started, but folks aren't required to contract with a PBM. They just choose to do so because it saves on prescription drug costs. And I showed you in that slide earlier, a plan that didn't use a PBM would see a lot higher costs versus those that did use a PBM.
So I'm just putting this against some of the things that I'm hearing in the national news, that like we're 2.5 times higher in the US for our prescription drugs than similar nations. And I think we spent like 603 billion. I'm just not sure how these all connect.
Sure, I'm happy to answer that. So other countries are able to negotiate drug prices directly with the drug manufacturers. Unfortunately, we don't have that in the United States due to the commerce. Well, there's a variety of legalese words out there, but the Commerce Clause is one of them. But currently, the system in the United States is plans or the United States government cannot negotiate drug prices with drug manufacturers. They are able to set it whatever they want to. And typically I hear that they will set the drug price in the US at whatever the market can bear. I think we've seen legislation. We might have even seen it in Vermont, but certainly other states. We talk about drug importation from Canada because drugs are cheaper in Canada just because the government is able to negotiate the price of a drug with a drug manufacturer. So without that ability, I think maybe that's why PBMs have become, what they are in the United States, because the United States can't negotiate with drug manufacturers, but PBMs have found an opportunity to do that. And I think that's why we operate the way we do.
Right.
So if we can't negotiate with drug manufacturers, how is Mark Cuban and his organization managing to, as a wholesaler, sell drugs without a PBM?
Sure, that's a great question. So Mark Cuban's Cost Plus they are a wholesaler that typically only deals with generic drugs. So I think they have about 2,000 NDCs out of 200,000 NDCs available. So they're only working with a very small subset of drugs. Again, those are generics. Typically, generics do not have any sort of rebates. Generics are typically lower cost and have been around for a long time and are proven effective. So wholesalers such as Mark Cuban's, Cost Plus, they're an interesting introduction to the market, and I'm excited to see what does happen with that. And if Mark Cuban Cost Plus can help drive down the cost of brand name drugs, which I don't think he's been able to do yet, we welcome that. We want to drive down the cost of prescription drugs. PBMs think that they are too high as they currently are.
So there is negotiation that can take place. And in fact, and when this will be for CVS when they're online as well, but you represent other PBMs. CVS themselves are, and that vertically integrated corporation are following the Mark Cuban model, in fact, and agreeing that the drug pricing system in the United States is overly complex, and the how the prices are decided needs to be simplified. Would you agree with that?
I would agree, yes, that drug pricing needs to be simplified, but drug manufacturers alone set the price of a drug. PBMs are only able to negotiate down that price, and we do that by creating competition amongst each other. I want to clarify that PBMs, including CVS or any of PCMA members, do not set the price of a drug. When a drug manufacturer comes out with a new drug, I can tell you they're not calling their PBM and saying, hey, what should we price this at? That certainly is not happening. They are creating their own price based off what the market can bear, and they are changing those prices based off supply and demand as well. If you take a look at the weight loss drugs that are all over social media and stuff like that, they're called GLP-1s. Ozempic is an example of it. Those just came to the market recently, and in the first or second week of January, they raised the price on those drugs, and they're now over $1,000 a month. And PBMs have no say in that process whatsoever, unfortunately.
Sam, this is the chair. So I have one question, and then unfortunately, we're going to need to move you to your comment specific to H233.
Okay, sure.
But my question is, I apologize if I missed this. How do PBMs make money?
So PBMs make money in a variety of ways based off how their contract is designed with the plan. So there are some PBMs who are completely transparent and everything is passed through. And basically a PBM just makes money on fees on individual claims. But then there's also scenarios where a PBM will retain some of the rebates or enter a spread contract with a client. And so they can make money off that. So there's not one way to answer that. It just depends on how they negotiate their contract with a payer.
Okay. Thank you.
Sure.
Yeah, so if you can switch to I think the first comment you want to make is spread pricing.
Sure. So let me go down. So let me go on the specifics of the bill. So House Bill 233, and I'm going to focus my first thing on spread pricing. So I think the version I'm looking off of is section 3612. It's page 12, sub F.
Okay.
And this would ban a practice called spread pricing. So spread pricing is a mitigation contract, which is offered by a PBM to pay for prescription drugs. And that's with the plan. But PBMs also enter a separate contract with pharmacies or their PSAO, which I didn't get to go into quite yet, but I can follow up on those transactions. What happens is the spread is the difference in those two separate contracts for drugs. Again, there's a price between the PBM and a payer, and there's a price between the PBM and a pharmacy, and that's where that spread can come into play. But spread pricing contract is completely voluntary, and no one is required to enter a spread pricing contract. So then why would a plan choose it? But a plans choose it because a spread pricing contract provides them with a lot more predictability when paying for drugs. And then on the next slide, you're going to see how a drug can vary from pharmacy to pharmacy. But if the pharmacy charges more than the rate agreed between the plan sponsor and the PBM, well, the PBM will lose money. But on the flip side, if the pharmacy charges less, the PBM will earn a margin. But again, the spread contract is more predictable, and that's why plans will choose to enter those. And then finally, I do.
So, I'm sorry, so, hold on, can you please go back?
Yep, yeah.
So are you saying you want, agree with this section of the bill?
No, sorry, we were opposed to this part of the bill. So we think the plan should be able to decide and build their own benefit. And we think that a ban on spread pricing would take away a plan choice to design the benefit which is best for them and their beneficiaries.
Who wins with spread pricing and who loses with spread pricing?
I don't know if there's necessarily a winner or a loser. It is all, I think it all depends on what the plan wants. So if the plan wants to have a lot more predictability on what they're going to pay when it comes to their prescription drugs for any given timeline, they might want to choose a spread pricing contract. Or if they want to be at the mercy of drug prices, how they fluctuate between pharmacies and list prices, then they will go with that, and it's a little more unpredictable. So I don't think there is an answer to your question as far as who wins or who loses. It is all about the plan having the option and freedom to design their own benefit.
Okay, so then depending on, and this might be a question for an insurer. If one plan chooses spread pricing and another plan doesn't, how do those differences affect the patient paying for their drugs?
The patient would not notice a difference unless depending on their, like, if they had a co-insurance. There's a lot of different factors that would go into it, Madam Chair. It would take me a while to answer that, and I'd be happy to follow up with you what the patient might see differently, but typically they wouldn't. If they have a flat copay, they wouldn't notice any sort of difference. If they had oh, sorry.
No, go ahead.
If they had a co-insurance, they might see a difference in prices, and that's where the patient might notice the difference. But again, that would all depend on the plan design for them to decide, and the PBM would just administer it.
Okay, my last question is, so then what would the effect on the pharmacist be?
I don't know that I would see anything on the pharmacy. The pharmacist agrees to these reimbursements ahead of time, which has nothing to do with the arrangement between a PBM and a payer.
Okay.
Okay.
Okay, so Maury, and then we need to keep
Two
going.
questions. So this is happening nationwide, but I'm just talking about Vermont now. We've lost about 75% of our community pharmacies, and across the board, they describe spread pricing and inadequate dispensing fees or dispensing fees remuneration that is less than it actually costs them to acquire the drug and dispense it, as being in that, and steering practices as being part of what forced these community pharmacies out of business. To the question of dispensing fees or the price a PBM pays the pharmacy, do insurers know on a drug by drug basis what the pharmacy is being paid? I'm not talking about aggregate. I'm talking about, does the PBM allow or share the information with the insurer on a dispensation by dispensation basis what the pharmacy is being paid by the PBM? In other words, are they aware, or have they been aware prior to legislation like this, that this has been harming community pharmacies?
Thank you for the question. I'm going to try and do my best to answer this. So PBMs will negotiate a contract with a pharmacy directly or through a group of pharmacies called a PSAO. And what happens is a PBM will negotiate the terms and conditions on reimbursements. And those are at a NDC or drug by drug level, yes. Does that help answer your question?
I think no.
So there's a negotiation between a PBM and a pharmacy or a PSAO, and then that same pharmacy will have a contract with a wholesaler to purchase their supply. So the pharmacy is going to purchase their supply from this wholesaler, and then they will also negotiate with a PBM on a contract to get reimbursed for those drugs based on the patient that walks through the door and what kind of insurance they have.
So I think you're not answering my question. I'm just going to leave it at that. And
I apologize.
my second question is, how many PBMs that you're aware of have stopped doing business in states across the country because of legislation like H233? How many PBMs have pulled out of a state?
Oh, I'm not aware of any directly related to legislation.
Thank you.
Okay, thanks, Sam. Keep going.
Sure. And then this actually is my final slide. So if you take a
Okay.
look, so there are varying drug prices across pharmacies, and expanding access to prescription drugs and bringing down costs, again, is the core of a PBM. So PBMs will work with a health insurer and providers, employers such as Blue Cross Blue Shield of Vermont to develop plans that include pharmacies that demonstrate lower costs for their members. PBM network pharmacies compete on service, convenience, and quality to attract consumers within a particular plan. This competition helps keep the rising cost of prescription drugs down while also prioritizing, a patient's health and well-being. And by building these networks of pharmacies, patients will have convenient access to prescription drugs at discounted rates. So if you take a look at this slide, various pharmacies will purchase drugs from a wholesaler at various purchase prices. Also, these pharmacies have different negotiated contracts with various PBMs, and that's where that spread might come into play. I don't know, Representative, if this might answer your question. So depending on the pharmacy and their arrangement with their PSA or wholesaler, they will purchase drugs at much different prices. As you can see, it varies from pharmacy to pharmacy. So, Madam Chair, that actually does wrap up my comments for today. I apologize for running so long on this.
Don't apologize. We're asking you questions. Please don't apologize. It was great.
Excellent. But yeah, this does wrap up my presentation. I'm happy to follow up or answer any questions. I do have some follow-up questions that I will provide the committee with,
Great.
And I will provide the committee with my written testimony as well.
Okay, wonderful. So I think Art has a question, and then we're going to move on to CVS.
Yeah, one of the purposes of this bill, as I see it anyway, is to protect, I shouldn't say protect it, keep our local pharmacies open. And I know from where I live in the Rutland, Vermont area, I've talked to a local pharmacy, and they're very concerned about the fact that they don't get reimbursed as much for a drug as much as they pay for the drug. And there's some mechanism which I don't understand, but they're losing money on certain drugs.
Sure.
And I want to know, if there are things that you folks do to ensure the viability of local pharmacies, which it's something that is a problem, and we want to try to keep at least some of our local pharmacies in operation.
Absolutely. Representative, thank you for the question. So let me be clear that PBMs need local and independent pharmacies in order to fulfill network adequacy requirements. So in the United States and Vermont, and I don't know if Vermont off the top of my head does have, requirements that a pharmacy has to be within X miles of a patient. So we do need those pharmacies to fulfill those network adequacy requirements. I'll start with that. Additionally, PBMs, as you can see on this slide, we want to design a benefit that keeps costs down for patients and payers. And that's why we design network pharmacies, to make sure that patients will go to those pharmacies that offer lower cost drugs. As you can see on the slide that's on the screen now, the difference in what a pharmacy charges for a different drug, adds up. That increases costs for plans and for patients through higher copays and premiums. That's why we have these pharmacies compete on price. And I am aware that Vermont, it is tough for pharmacists. I empathize with pharmacists. We want them to remain open. We need pharmacies to stay open. We need them in order for the PBMs to stay in business even. So, I understand the frustration, and I know that there was a big bill passed, was it previous session or the session before, and a lot of their concerns were addressed in that bill. And, one of the concerns we have with this bill now is, we're waiting for those to, set in and see the results of that. We're concerned with some unintended consequences, and we think that advancing with this bill already on top of, what was passed previously, is an additional concern as well that will raise costs.
Thank you.
All right. Thank you, Sam, very much. We appreciate your time.
Thank you.
Look forward to getting the questions answered. All right, and now I think we have Stephen Larrabee. Did I say that right?
Can you all? Yes.
I'm not sure we can hear you. Can you introduce yourself and we'll see how it's working?
Yes. My name is Stephen Larrabee, and for the record, and I work for CVS Health as State Director of Government Affairs. Can you hear me okay?
Yes, we can. Thank you.
Great. Well, thanks so much for having me, Chair Ho and members of the committee. 2 years ago, I testified in front of this committee on House 353, and what became Act 131. And at the time, I want to get at the onset, it's always a pleasure to testify in Vermont. It's my home state, and so I take a lot of pride coming back to testify. I was born and raised in Danville, Vermont, Northeast Kingdom kid, so it's great to be back. I wish I was there. My focus on the testimony and what I'd like to do, I echo a lot of what Sam said. And what I would be happy to do at the end is answer any of your questions from my perspective on any of the other topics, rebates, spread, copay accumulators, mark cubing cost plus, vertical integration. I'm happy to do that. I really want to hone my testimony to a specific 2 sections of the bill just to speed along. Then you all can discuss the rest of my time.
Okay, thank you.
So the focus of my testimony is going to be on page 22 of House 233, specifically subsection D and the second sentence of subsection E on that page. And I said it was like deja vu all over again with House 353. These sections were specifically removed in the House consideration of 353 back in March of 2022, and I spoke to these sections at that time. I want to start with my primary concern, which is the second sentence starting on line 12 of page 22, which was expressly, again, eliminated from Act 131. Existing law, starting on line 9, subsection E, says that PBMs must pay unaffiliated pharmacies more than affiliated pharmacies. And at the time, we generally said that that was fine. We already know that we pay independent pharmacies more than we pay CVS pharmacy. And so we generally signed off on that. What I will say, unintended consequences on our part, I did say we were generally okay with it at the time, is that we've run into some of the issues nationally where other pharmacy chains, think national chains, online pharmacies, big box stores, not brick and mortar Vermont pharmacies, have come in and sought contracts with our PBM for less than we reimburse CVS pharmacy. And so now as a result of this language, we have to reduce reimbursement for CVS pharmacy because this language says so. But I don't want to relitigate that particular point. If that stays in, that's fine. Last session, we removed the second sentence because it creates significant operational and financial challenges. The language is a little unclear, but as I read the language, it says that a PBM can not only not pay an unaffiliated pharmacy more, you can't pay an unaffiliated pharmacy less, but the payment to the unaffiliated pharmacy has to be on a per drug basis, and the unaffiliated pharmacy must be paid at their acquisition cost and a dispensing fee set by DVA or Vermont Medicaid. So I think this begs the question that for a PBM like CVS, an unaffiliated pharmacy presumably means everybody else other than CVS pharmacy. And so I kind of beg the question, is there a need for MAC regulation if we are mandated to pay everyone a set rate? To get into the specifics, the dispensing fee, and this was noted in the Act 131 report. I will give kudos to the Department of Financial Services. I don't think we agreed with every word or line that was in the report, but we spent a significant amount of time submitting data, talking with DFR, and it was a very thoughtful process. But in the 131 report, they noted that Diva's dispensing fees are substantially higher than the commercial market, right? And to a certain extent, that makes sense because, as we talked about 2 years ago, Medicaid typically pays less for the ingredient cost of a drug, but pays higher for the dispensing fee. Whereas in the commercial market, you typically pay more for the ingredient cost and less on the dispensing fee side. So today, Diva's, again, according to the 131 report, the Medicaid dispensing fees is $11.13 for generic and brands and $17.03 for specialty drugs. That's per prescription. That contrasts with what PCMA uses $2 as an average dispensing fee in the commercial market across all lines of drugs. And the Act 131 report actually cited another study that says that the average is less than that. What we typically find is that the average probably overstates chain pharmacy dispensing fees and understates independent and smaller pharmacy dispensing fee rates, but you get the average that you get. The point I'm trying to make here is that any mandated amount above what's used in the commercial market today would simply add to healthcare costs, whether it's borne both by the health plan and by members, especially those who are in their deductible or cost-sharing phase. So the report makes a simple calculation that talks about if we were to apply, and they use a lower number, but $10 dispensing fee, and the average today in the market is $2, they subtract $2 from $10, you get $8, and you multiply that by the number of claims, number of prescriptions in Vermont, and they came up with that adds $25 million to Vermont prescription drug costs. We've looked at it in other jurisdictions as well, and our analysis based on our membership in other jurisdictions, and we usually take representative samples, like we'll pull 250,000 random members in a state, for example, and run an analysis, and we'll just reprocess their claims at a higher dispensing fee, is that the impact is roughly $60 to $70 per member per year, is what the impact of and that's at a $10 dispensing fee. That's the CMS minimum dispensing fee. That translates into an 11% increase on health plan costs and a 7 to 8% increase on member cost sharing, right? Because again, if you have a generic drug that would otherwise you pick up for I was actually looking at my generic drugs and I picked up amoxicillin recently for my daughter because I have small kids and that's all we buy these days is amoxicillin. I pay $4 at the pharmacy, right? So obviously that $4 is both the ingredient cost and the dispensing fee. If there was a mandatory $11.13 dispensing fee, the price of that drug would be some amount significantly higher to me out of pocket because I'm in the deductible phase of my benefit, right? The second problem in this section is an operational challenge with regards to the language that says that we have to reimburse based on the actual acquisition cost of the drug. We don't know the pharmacy's acquisition cost of a drug. It's not known to PBMs what a pharmacy purchases their drug for. And I provided a paper on this to the committee that I think was posted online and that you all hopefully have access to.
Yep, we do.
And the reason we don't know that is because generics are a commodity. Generic drugs in particular are a commodity. The price bounces around. There was reference to NADAC yesterday in your testimony, and so you can go online and pick a random drug like a NADAC. Again, I did amoxicillin before the committee hearing, and the price of amoxicillin has bounced all around, up and down, with a trend line, obviously, typically up over time. But where the pharmacist buys that drug on that trend line, that again is bouncing like this over time, is not known to the PBM. And so while we are, again, comfortable with the first sentence of E, saying that in the aggregate, we agree and will pay pharmacies, unaffiliated pharmacies, more than we pay ourselves, we can't guarantee that the spot price on a day for a drug is going to necessarily be higher. We will make sure that at the end of the year that they get paid more for those drugs. And so the last thing I would just say is that in some states, we've seen where either regulation or the bill has said, well, you just have to pay whatever the invoice price is for the pharmacy. Whatever their invoice price is, that's their acquisition cost, the invoice coming from the wholesaler. And in the paper that I provided, I just want to make sure it's known by the committee that I suppose just like rebates, as we discussed previously, pharmacies also get discounts that are after not included on the invoice price. There is volume discounts and there are other discounts that come off that are not reflected in the invoice price of a drug that lower the net cost of those drugs. And so we want to make sure, we don't think that the acquisition cost is an appropriate metric to use. It's further not defined in the bill anywhere. Actual acquisition cost is just a terminology, presumably a term of art. It's a term that's used in Medicaid, again, so perhaps that's where it was pulled from, but not defined for the commercial market. And the last thing I just want to say is, and this references the beginning of my testimony, these provisions apply to all pharmacies, not just independent pharmacies. They could also apply to large chains, online sellers. There's all kinds of new pharmacies coming on around the country. And so I would respectfully ask that those sections like 353 come out of the bill because they are both a logistical nightmare and a substantial cost increase for Vermont ratepayers. The last thing I just want to say very briefly on a section, and this concludes, and then I'll open up the testimony on licensure. We're fine with licensure. We've worked with folks on licensure in other states. I think our concern with the language in the bill on licensure is only that we want to be treated equally to other entities licensed by the Department of Financial Regulation. That if they have the ability to set license fees, that those are comparable. That if there's penalties, that those are comparable to other entities licensed and regulated by DFR. That if there is reasons for revocation of license or suspension of license, that those reasons are comparable to other licensed entities. And I would call out that in section 2613, subsection E, there's a private right of action for pharmacists in the bill, which I think is pretty unusual and unique relative to any other licensure statute I've seen anywhere else in the country. And I'm not sure that there's a parallel in the medical or health plan space that would make that appropriate. Again, if we violated a law under Vermont, there's remedy by the Department of Financial Regulation in previous sections to fine us, penalize, suspend our license. There's right of action for consumers if they've been harmed, but I'm not sure why there would be private right of action for a third party. It's to my knowledge, there's no analog in the medical space where, say, a hospital could sue a health plan or a doctor group could sue a health plan for some aggrievement. So I think it could become a litigator's nightmare or blessing, and I've never seen it in another jurisdiction or bill. So with that concludes the two topics that I wanted to specifically raise. Again, we echo Sam and his concerns, and I know a health plan partners come up, but I'm happy to answer questions.
Thank you, Stephen. And if you could put in writing, I see you have in your testimony, this is from May 2021. If you could just put in writing what you oppose in the bill, and if you oppose something and have suggested language, put that in writing as well. That would be really helpful.
Sure. I would ask that you remove the sections that I just, as you did in 353.
Okay, if you could put that in writing to us, that would be really helpful.
Yeah.
Thank you. Mari and then Art.
Thank you, Stephen. I just want to acknowledge, acknowledge the difficulty, controversy, challenge of determining professional dispensing fees. And that has been, as I mentioned earlier, one of the cruxes of the problem that's caused community pharmacies to go out of business. And it is challenging to come up with a plan that will catch up the dispensing fee so that it's fair. And I'll just say in general, that's what we're trying to get at. And you mentioned NADAC, using a standardized accepted tool to determine what a fair dispensing fee would be. And I hear you about how you feel about this methodology. And I do want to investigate further with the other stakeholders about the per unit or the per unit by per unit. I hear that. But just want you to know that this is a really important part of H-233. And then the point about the private right of action, obviously that was intentional. And I'll just, yes, it is unusual but intentional. I'll just leave it at that.
Art.
Yeah, I just want to verify, Steve, the sections that you want to take out. I'm on page 22 of the bill. It looks like B in its entirety would come out. And then on line 12 under E starts the reimbursement amount and that whole sentence. Are those the two?
Yeah, and I suppose we could come back on, because on D, so to your answer to let me be clear. E, the second sentence, we would recommend striking the second sentence of E. The reimbursement amount shall be starting on line 12.
Yep.
On D, I think there, and again, while I don't agree with every word in the 131 report, I think they tried to outline a process where if there wasn't a fair appeals process, that there would be some ability for pharmacies to be reimbursed. I think the problem is that the reference to acquisition costs is unknown. And so I don't know how we would get to that. As it is, you're already required under this gets really nuanced, but under the MAC process in existing law, you're already required to update the list every 7 days, and it has to be widely available for purchase by pharmacies in Vermont from national and regional wholesalers, and cannot be obsolete or temporarily unavailable. So that's required. And so a pharmacy goes through the appeal process, and let's say it's denied. This in the D deals with issues in which it's denied. So they've appealed and said, we didn't buy it at that price, so we want to appeal this decision. D goes on to say that you have to supply both the drug code, the wholesaler, and the day that it was purchased. And if you don't, or if it's not available at the price you said, then you have to reimburse at their acquisition costs. And my point is, we feel like we already have to do that. And then 2, we don't know what their acquisition cost is for which to submit reimbursement if they were successful in this provision, right? So my suggestion is to take it out, or we could try to work on something. We could try to look to other states if there's a need, but I'm unclear on the need for the section.
Okay, let me ask you this. Do other jurisdictions legislatures get themselves deeply involved in this type of thing?
Yeah, so I mean, you all talked about, there's a lot of PBM legislation that's out there. I will say that you all have been between 2 sessions and 2 different bills now in 2 sessions. You've been as involved as any in my territory in New England on PBM issues. And the nuances of some of these are as aggressive as I've seen in other jurisdictions in New England. Again, I cover New England. And so like a bunch of states address MAC. You guys have taken probably, the language in front of you is about as far as I've seen on MAC, right? There's a lot of places that have addressed spread or have addressed copay accumulators or whatever, and you guys tend to be as far on that issue as I've seen.
Thank you.
Stephen, you're from Vermont. You know we like to be first on a lot of things. If you have suggested language on that section E for acquisition costs, we would appreciate it. If you don't, that's fine. I think we're good. Thank you for your time, Stephen. We appreciate it. And obviously, as the bill changes to both you and Sam, stay tuned to our website and new drafts. And if you have comments, we're happy to hear them. I think we're going to go to Jordan next. Jordan,
Hello
welcome back.
Yes, and my camera's working this time. I apologize for my technical issues and challenges this morning.
No
So for
worries.
the record, Jordan Esty, Senior Director of MVP Healthcare. Again, MVP's comments on the bill are from the perspective of a purchaser of these services, not as a PBM. Just for some background, MVP doesn't own or operate a PBM. We're a smaller company, so we don't have the scale or resources to negotiate with drug manufacturers. So we rely on PBMs to help us manage the prescription drug benefit for our members. The terms of that arrangement tend to focus on negotiation of drug prices, network management, drug utilization review, and claims processing. But MVP manages its own formulary and our clinical management programs around the prescription drug benefit. So on the bill, and I will provide my comments in writing, I just have a couple of points I'd like to offer. Spread on section 1, dealing with a prohibition on spread pricing. MVP is neutral. We do not use these arrangements in our PBM contracts in Vermont. Also in section 1, page 11, lines 14 through 21, it looks like an established prohibition on copay accumulator programs. We are neutral on this because we do not use them in our Vermont commercial business.
And I'm sorry, what can you say where that was again? I'm just having trouble following.
Section 1, page 11, lines 14 through 21. And again, I'm happy to put this all in writing and submit it.
Yep, thank you.
Okay, so on those pieces, we're neutral. I do want to flag a significant concern under subsection E1, starting on page 10, line 19. But our concern is really with the definition of cost sharing amounts under subsection E2, which is on page 11, line 7, because that definition, how that definition is utilized and applied under the broader provision, I think is the concern for us. So that section in general would limit what consumers can pay out of pocket for their covered prescription drugs by establishing a lesser of standard based on one of 3 things: the patient cost share amount, the maximum allowable cost for the drug, or the cash price of that drug. Now, the definition of cost sharing amount is what has us concerned because it would require pharmacy rebates to be calculated and applied at the pharmacy point of sale for an individual member for an individual prescription or drug.
Jordan, I'm sorry. Can we stop you there for a second?
Yes.
Are you on page 11, section 2?
E2, yes. It's where it says as
It's
used
on the previous page.
So I think that part is already current statute.
No, that is not.
So starting from line 7 down is not.
Line 7,
Okay. I have
Okay,
that.
sorry for that.
Sorry about that. I had it marked wrong.
Now, there's a lot of references. I just wanted to make sure we're talking about the same thing. It's specifically, The copy I had, page 11, line 7, as used in subdivision 1A of this subsection E, the cost sharing amount under the terms of the health benefit plan shall be calculated at the point of sale based on a price that has been reduced by an amount equal to at least 100% of all rebates received or to be received in connection with the dispensing or administration of the drug. The PBM shall pass on any remaining rebate amount in excess to the health plan. So, our concern here really is with the definition of cost sharing amount, because the way that this will be applied is a fundamental change to how the pharmacy benefit is managed today. And we're concerned about the complexity, the confusion, and the abrasion for consumers, as well as the potential for added cost. And we heard a lot of discussion earlier about rebates and how they are typically negotiated, how they're reconciled, and how those amounts are paid back to the health plan, which in MVP's case, we're then able to use to lower expected cost and drug spending, and that is reflected in the premiums that we charge to our members. So those rebates are reconciled at least annually, and again, MVP uses those funds to effectively reduce member premiums. Our concern is not an endorsement or opinion about rebates, but really the impracticality and the costs associated with putting this into place, which would put our members in the middle of very complicated transactions. So at the point of sale, for example, we don't know what a rebate amount on a particular drug will be in order to apply that reduction to the member's cost. And this raises all sorts of questions down the line about how you effectuate this, right? So if at the end of the year or at the end of the period where our rebates are reconciled and the amount changes, does the member potentially owe a repayment to us? I mean, that's a terrible member experience, and I don't think any of us want to be in the position of trying to chase members down for that information. So the reality is it probably forces us to, anticipate extra costs that are reflected in the premiums. Not to mention, kind of related to our discussions this morning about H766, just the building this entirely kind of new approach around these pharmacy transactions. It would require a lot of time and resources, which would be very challenging for a smaller plan like MVP. And I want to flag that the concept is not a new concept. It's been out there, and the federal government has looked at it, but the federal government notably has effectively delayed any implementation of a similar proposal in Medicare until at least 2032 for very much the same reasons. And more of a kind of a technical point, I think it would definitely be more complex even in commercial because of the unique nature of commercial benefit plan designs with deductibles, higher out-of-pocket amounts than somebody would pay under a Medicare Advantage program. Okay.
Got it. Thank you.
A couple more quick points. Section 1, page 23, lines 17 through 20, establishes or prohibits a PBM or health plan, I guess, from requiring any tracking information on a claim about when a 340B drug program is used, or when a 340B drug is used. Neutral on the section, certainly we, I think, appreciate and support the important role that 340B plays in the safety net delivery system. But, as it relates to my last comment about point of sale rebates, if a 340B drug is used, then I think technically there can't be a rebate on that drug. And we would not, if there's no information on the claim, we wouldn't be able to account for what a rebate may or may not be. So that's really kind of a technical point as to how those two provisions seem to contradict each other or don't work together. And then, this is more of just a policy observation, and maybe there's some context and background here that I don't fully appreciate, but the ban on requiring any flagging of a 340B drug as part of a claim transaction doesn't extend to Medicaid, right? So as a matter of public policy, I just raised the question that, if it's not the PBM or an individual health plan, collectively, why wouldn't we want to understand at least how much the 340B program, what the net effect is on overall drug spending, as I assume, policymakers in Medicaid, state and federal policymakers around the Medicaid program would want to understand that information for.
So Jordan, I appreciate all that, but I'm being told by our legislative council that this is current law.
Fair point.
Okay, thank you. But we appreciate your concerns.
Neutral in this observation.
Okay, thank you.
And then two other quick points. One is Applicability of fines, again, under section 1, page 13, lines 4 through 7. The commissioner may impose a penalty on a PBM or the health insurer with which it is contracted, or both, for a violation of this chapter. Penalty shall not be less than $25,000, nor more than $50,000 for each violation. Now, I guess we would appreciate further clarity on, that authority and when it might be leveraged, just because of the, as it's written, whether it could be, when it could be applied to a health plan or a PBM, but further, what type of violation are we talking about? If it's something around like an inappropriate cost share being applied because a rebate wasn't applied at the point of sale, that's on a per transaction basis. I assume the intent is not to fine MVP, for example, $25,000 for every such potential violation. So just more clarity on the penalties would be helpful. And then last comment is on, I'll get the page number for you. Section 1, page 22, lines 17 through 21. The provision would prohibit a health plan or its PBM from withholding reimbursement for services on the basis of non-compliance with participation requirements. And that's really the last portion of that subsection F. After federal law, it says common, nor shall it withhold reimbursement for services on the basis of non-compliance with participation requirements. We would welcome additional clarity on the intent of that last portion, starting with nor shall it. We don't really understand what is meant by participation requirements, and I think that's an important question, as for our understanding, at least as it relates to a contract between a health plan and a PBM or a pharmacy. So while the intent of the first portion of the provision, which would prohibit a health plan or a PBM from imposing requirements on a licensed pharmacy in excess of those set by the Vermont Board of Pharmacy, seems clear. To our knowledge, that body has no jurisdiction over participation requirements in private contracts. And if that's the intent, we would oppose it, but certainly welcome further conversation. Perhaps our reading is not correct.
Okay, thank you.
Thank you.
Any questions for Jordan? And remember, we don't have much time. But this is not the last time we're gonna have this conversation. Questions? Great, thank you, Jordan, very much. We appreciate you being with us today.
Appreciate the opportunity. Take
Sarah?
care.
Welcome back.
Sarah Teachout with Blue Cross and Blue Shield of Vermont. Just to set the landscape a little bit, again, Blue Cross is a small health plan. I know you heard earlier a few days ago that some Blue Cross and Blue Shield companies invest in PBMs. We are not one of them. We are not vertically integrated with any PBM or any pharmacy. So we contract for PBM services like we do all kind of other vendor contracts. Our current contract is with Optum Rx, so it's one of the big three that you've heard about. And through our affiliation with Michigan, which also contracts in the similar manner with Optum, we're hoping to eventually achieve some economies of scale through that contract. That was one of the benefits that we identified from being part of that relationship. So I will be quick through these sections. We are also neutral on the licensing of PBMs. I won't go into all the details, but we did have very similar issues as MVP on passing through the rebate at the point of sale. And it's because we are paid by the PBM, the rebates quarterly, generally on a look back basis. So they look through all the claims that have been filed on behalf of our members, pay us the rebates. We use the rebates on an annual basis to lower premiums. So that's how they get passed through to members. We do not know, even if it's a drug for which we typically expect a rebate, if we will always be paid the rebate in that situation. The example he gave is a good one. PBMs refuse to pay rebates for drugs that are filled through the 340B program. We don't know at the point of sale because of the law you passed a couple of years ago if it's a 340B drug transaction. So they take that stuff out afterwards, not at the point of sale. That's the easiest example for me to give you, but there are other types of instances where they don't pay the rebate. So we won't know that. On the manufacturer, so what we're calling the manufacturer coupons. So Blue Cross and Blue Shield of Vermont currently passes through the manufacturer coupons to our members in their copay and their deductible calculations and their out-of-pocket max. So any changes there are not going to affect prices for our.
Which section is that? I'm sorry.
Oh, so the deal with this bill is that it's 316, section 316, little e, little 3 on page 11. And there's more language on page 26, big F, and I'm not sure if they're compatible sections. I see her not there, but it's in two places, and I'm not exactly sure why, but I'm sure they're related. So we do believe, I know you had testimony yesterday that this does not affect but we do believe that manufacturer coupons are used to incentivize patients to choose drugs that have higher overall costs and drive up prices overall, certainly not for the individual member. We get the individual person going in with their coupon, it lowers their cost. I will, when I provide you with this, there's a study in JAMA that cites that. So that is one of our concerns always with this. And there are some policies that other states, California and Massachusetts have been doing around coupons. So I believe California and Massachusetts ban them if there's a generic available. So not for, single price brand drugs. And there's some other consumer protections around coupons you may want to consider. Things like if the manufacturer offers it sort of in the beginning of the person's script, you might want, if it's possible, require them to offer it throughout the entire script so they don't get 3 months in and then the coupon's no longer good. So those are the kinds of things we would recommend to protect consumers, because we do know that these coupons are pretty important for people with their out-of-pocket. The last thing I will say, and I feel like I have to bring it up, is that manufacturer coupons are illegal for the Medicare and Medicaid programs because of anti-kickback statutes. So I get why we're doing this. It totally makes sense, but we're putting for commercial payers in law something that's illegal for Medicare and Medicaid beneficiaries. So
Explain that.
yeah.
I'm sorry.
I thought it was interesting too. And it's just sort of irony of everything that goes on in drugs. But it is illegal for drug manufacturers to offer coupons to people covered by Medicare and Medicaid. And this means if you've ever tried to use one of these coupons, they ask you all these questions before they'll give it to you. And they say, are you covered by a state Medicare or Medicaid program? So that's because the anti-kickback statute prohibits the knowing and willful offer of payment or remuneration to a person to induce the purchase of any item or service for which payment may be made by the federal health program. So
I didn't quite hear it.
right. So our concerns about the prohibition on spread pricing is that we are concerned it would increase our overall costs for our members. We would have to renegotiate our contract, to be quite honest. Our contract has spread pricing as part of it. So we would need to renegotiate that, forcing us to go back to the negotiating table with our PBM in the middle of the contract puts us in a difficult position, negotiating position. And we think that this would increase prices for our members. So that's our concern there. It's certainly a way you can structure it.
Can we ask a question on that real quick, Marty?
Sure.
You might have said this in one of the times you've been in front of our committee, but when do you renegotiate with your PBM? And is it annually, every few years?
It's not annually. Generally, I don't know the dates is what I can't tell you right now, but generally we negotiate for a 3-year contract and then it has extensions. And then I think it's about every 5 years, we open the whole thing up and put a bid with all the PBMs.
Can you get that info for us?
I can ask, definitely. And I think what we would ask here is we would prefer it to, if you're going to make a change like this, have it start at the beginning of a plan year. I think you've got it right now in July. So that's midway through a plan year. So that's difficult. And we would prefer to wait and renegotiate it at the start of a contract, but let's see. We also, and it's clearly your policy, but we also oppose the section that would allow a pharmacy to avoid the outcome of a denied appeal by charging the health plan
You might not.
payment. Yeah, and the reason we oppose it is it's not, the money's not coming from Blue Cross and Blue Shield of Vermont. It comes from our members. So anything that you do that increases costs, that's where they go.
Where are we there?
This one is on page 22, section 3631D, little d. We can't think of any other instances where this is part of the legal process, but so then the next one, which you heard a lot about from everyone else, I can't speak as well to the cost in the acquisition, the actual acquisition cost plus the dispensing fee. Clearly, it is the intention behind this bill to increase revenue or payments to pharmacies. So just taking that assumption, that money has to come from somewhere and that will come from our members. So when you increase the prices paid to pharmacy, you increase the prices paid by consumers. So that's our concern with that section. In summary, I have asked for what specifically the dispensing fee increases will cost, because that one should be easier to tell, number of scripts we fill times the dispensing fee. I don't have the number now, but I think we're talking about millions. The other part about the actual acquisition cost, I think that one's harder for us to figure out, especially quickly. So then under patient consent, which is on page 27, we support having patient consent before changing a drug order in the pharmacy location. That's totally fine. We really want to make sure, and maybe it's not an issue, that this doesn't undermine the generic or biosimilar substitution laws. I'm not sure if it does. I'm just asking the question. And then
Say it again.
yeah, it says you have to have patient consent before changing a drug order and pharmacy location. I'm sure Jen can answer this when she reads the statute. We just want to make sure that we can still do generic substitution and biosimilar substitution.
Yeah.
I don't think that's your intent here.
No.
And then the pharmacies, the one other thing that we are a little bit concerned with is that requiring a patient to fill their prescription at an in-house pharmacy owned by the facility that they're getting the script written at. So you see your doctor, they're part of a larger institution. We would prefer it if the institution's requirement isn't that the script has to be filled in-house.
But the patient should have a choice where
They should have that, yeah, it's choice there too. It doesn't quite fit in the way you've drafted it. You'd have to figure out how to.
Couldn't you?
So I'm on page 27.
Okay, me too.
It's 8 VSA section 4089J, and it says patient consent.
What lines are we talking?
10
to 13?
Yeah.
27. Yeah, that's it.
Oh, I mean, just not alter it without patient consent. E?
What line?
11, E.
I'm sorry. And you know what? In my memo, I'll try and make sure I'm clear.
Page 27, 11, 12, and 13. A health insurer, pharmacy benefit manager shall not alter a patient's prescription drug order or the pharmacy chosen by the patient without the patient's consent.
Totally agree with
Oh,
that.
you're okay with that?
No, we totally agree with that.
Sorry, got it.
All we were concerned about was generic and biosimilar substitutions. You have to get patient consent to do that. And then the other topic I mentioned. So that is the end of my specific concerns. I think overall, we are just worried about cost increases to consumers. So to the extent that this increases the cost of prescription drugs, it will increase the cost of premiums and out-of-pocket costs. We know those pressures are already significant.
Thank you. And you'll send us that.
Yep, yep.
Okay, thank you. I'm sorry, this has been a jam-packed day and you all have had no break, so I really apologize for that. But now we're gonna rush to the floor. We'll see you tomorrow. We do not start tomorrow until 9:15. I'm giving you 15